but I will tell you that as of right now, and I will change some of it, but as of right now, the first 50 questions are multiple choice. There's 50 questions, the first 50 are multiple choice. After that, okay, like the last the last 3 pages of the exam are put into a category of like what we call level 3 questions or case studies, to where you have to kind of put stuff together, okay? And so basically, the entire exam is multiple choice, and then you get, what I'll have you do is I'll have you take the exam, you'll take it on the Scantron, okay? You better make sure that the bubbles on the Scantron match the answer you gave on the test, okay? I'm telling you right now, if you have an answer on the exam and you put C, and you transfer it to the Scantron and you put B, all right? If C was right and you had it circled on your exam, you do not get credit for it, okay? Now the reason that I'm like that is because you're going into a profession to where you can't make mistakes when you write something down and you transfer it. Anyone that's in this class, if I don't care if they're a phlebotomist or whatever, I know that we've got some in here, you talk to those people, because I'm just telling you, I worked in a lab. You have to be a person that you pay attention to detail. Like, you can't write down a number 8 when the answer you're supposed to be writing down was a number 6, okay? Because that can have bad consequences. Luckily, they're going to computer and all of that stuff, but I'm just telling you, I want you to be the type of person to where you don't put one answer and then transfer it to a different. Could you imagine what would happen if you blood typed a patient and it was A positive, but you wrote down on their card O positive? You understand what I'm saying? That's why whatever answer you put on that test has to be on that bubble sheet, okay? And, that's the way I am. Same way with leaving stuff blank. If you leave an answer blank, guys, you gotta answer that. You can't, if a doctor wants test results, you can't leave the mono result blank, right? You gotta document it. And so, I'm helping you in the long run. You may not like me now for it, but I'm helping you in the long run, or I'm at least telling you how it'll be out there. Same way with drawing blood. Okay, I'm not trying to get off on a tangent, but we're gonna finish early today. You know, I've had a few of you, and I'm not picking on people, but I've had more people than I would like to see in this class and radiographic phlebotomy that hand me a tube of blood and it's got one name on it. It says Kim or Patricia. You know what I mean? And it's like, that is so wrong. Like, I want to say, you're going to have to draw that again, because don't hand me a tube of blood with one name on it. Even though I know in this setting we all know each other, and you're thinking, what are you talking about? I drew Darren, you know. Well, if you just wrote Darren on that tube, I mean, you can get in so much trouble for that in the lab, because you have to have a last name on it. There's probably 5 Darrens at CHI right now in the hospital. So if you put Darren on that tube of blood and it goes to the lab, you got people that are hardcore down in the lab that see that and they go, whoa, they throw it away. They throw it in the sharps container. And they're not even going to give you the time of day to get you to relabel it. They're not going to let you, okay? Now, hopefully you're working at a place that has barcoded labels that will have Darren Branniger, his birth date, his doctor, the test they want, where you just stick that label on it. I know that, but for this class, it's really important you understand that you put a first and a last name on that tube of blood. I told you guys the story about me drawing that guy named Mark Grayson. Have I ever told you that story?
And like there was another Mark Grayson?
Yeah, Mark Grayson. How common do you think that name is? I'm at the VA, it's my first day to go draw blood. I got my little basket and I'm going up to the floor, and the first person I'm supposed to draw blood, I'm nervous because it's, you know, this is like the very first day I've ever had to go draw blood by myself. I had like 10 patients I had to draw, and I remember I had to draw a guy named Mark Grayson. So I went to the room, and this is back when they had the names and stuff on the outside of the room, and it said Mark Grayson. So I went in, drew the blood, and you know, drew everybody else and did my thing and went back down to the lab, and somebody in the lab said, now, you know, there's 2 Mark Graysons up on that ward. I'm like, no way, you know, and I just got lucky and happened to walk in the right patient's room, but I very easily could have went to the other Mark Grayson. You know, I'm breaking HIPAA rules by telling all that a long time ago, but would you think Mark Grayson, would you think there'd be 2 Mark Graysons on one ward of any hospital for that matter? Okay, so now change Mark Grayson with the name Chris Smith.
Yeah.
Now, so what are the odds? What can happen?
Yeah, because most of the plasma that we had yesterday had the last name of Smith. I mean, even my last name's Smith, so.
Oh, yeah, but I did that on purpose.
Oh, okay.
I labeled all of them. I wanted all of them to see it's like. Okay, let's go over the review. You're welcome to record this. I'll go slow, stop.
Oh, it doesn't matter.
Whatever you need to do. I'm big on review questions in the back of the chapters, especially if we went over them in class. If I went over a review question or if I went over a case study, I would look at that case study. There's a reason that I do everything, okay? Because again, I've been teaching this for a long time, and I do it in a way to where I'm hoping you're paying attention for the most part. So I've already stressed things very highly that will be on the exam if you've really been paying attention. But I've got the exam in front of me. So there's a few things that I want to go over. The first thing I want to go over is I want to go over normal ranges. I've already looked through the exam. There are about 3 questions on this exam that you will get correct if you know a few simple normal ranges that we talked about in class, all right? So one of them, let's go over things and you guys can participate as much as you want. This whole 5 days or this week has been about coags. So I'm not gonna ask you any normal ranges that don't affect coags except for platelet count, right? Which you probably had in the other part too. What's a normal platelet count range? Around that. So you could recognize that in a multiple choice question, right? Now I may ask that question in a way to where I say a patient has a platelet count of 95 times 10 to the third. This would be what, okay? So what would that word be for if a platelet count, if a patient has a platelet count of 95 times 10 to the third, I'm assuming that you know that that means 95,000 per microliter.
Yeah.
Okay. And I'm also assuming you know what the normal platelet count is between 150 and 400,000. And now I'm assuming that you know 2 terms, thrombocytopenia and thrombocytosis, and that you can look at that result and give me the right answer. So do you see how many things I just took care of by asking you that one question? Okay. So what would that be? Platelet count? Thrombocytopenia. So if I said a patient had a platelet count of 900,000, that would be thrombocytosis. Okay. So both of those questions aren't on the test, but one of them is. All right, so that's how we're going to do this review. I'm not telling you what's on the test, but I'm trying to get you to where normal ranges are important. Okay, so we've taken care of the platelet count. Another normal range that I'm pretty high on is knowing the normals for a pro-time and a PTT of a patient that is not taking blood thinners. I've went over that several times, right? I just want you, again, I just want you to know that in most case studies in your book, they'll have the normal ranges in parentheses out beside that, right? But I want you to know, a normal pro time on a patient that's not on nothing, it's around 12, okay? And a normal PTT
30?
is around 30, right? So if you see a result that's 60, all right, that's elevated PTT. If you see a pro time that says 25, that's elevated, okay? Remember, those normal ranges are in the very front of your book, okay? And it even has, if you guys will turn to the front of your book with me, you see where, look at the bottom, it's like the last 2 paragraphs on that cover or whatever, it says basic hemostasis profile and other hemostasis tests. I can tell you right now, you need to be real interested in pro time, PTT, bleeding time, and platelet count, all of them. All of them in that section you need to know. I'm looking at like 3 of them that are on the test right now. So there's no reason you don't get that right.
So if we wrote 11 to 13, like it says there, we'd still get it right, or?
Yeah, or be able to recognize it. Don't memorize 11 to 13 and think you're out of the woods, because I may put it in a case study where I say the patient had a pro time of 12. You need to be able to recognize that's normal. Okay, that's a normal range. Under the other hemostasis test, the one that I'm most probably concerned about out of all of those is that one fibrinogen, 200 to 400 milligrams per deciliter. We're going to do a fibrinogen titer today, okay? So, not every one of those normal ranges will be on the exam, but you'll be happy you studied that page, all right? All right, let's look at chapter 15. chapter 15, I went over a picture that I really liked at the bottom of page 236. It shows a platelet response to a vascular injury. But remember, I said, okay, this is how this works. You have a break in the vessel wall, and you're gonna have exposed collagen. For all of this to work in sequence, that collagen, okay, links up with von Willebrand factor. And then von Willebrand factor links up with a glycoprotein on the platelet surface, right? That's called platelet adhesion. That's where the initial platelet reaction occurs at, right? If you look, that glycoprotein on the platelet is called glycoprotein 1B. And there may be a question where it says platelet adhesion involves, for example, von Willebrand factor linking up with glycoprotein 1B. The reason that I'm being a stickler on that is because look at the picture up on page 237 in the right-hand corner. Remember when I told you, okay, you got a big, huge platelet coming in to link up with that other platelet? You with me? You seeing that picture? Those glycoproteins that fibrinogen has to be involved with is called glycoprotein 2B, 3A. So I don't want you to know all the glycoproteins, but know the difference between those two, where a platelet links up with a platelet and then where platelet adhesion occurs. All right, some other level 1 questions that you may see on this exam. I hope all of you know this by now. But we need to talk about platelets, all right, again. So let's go over a couple just what I call quick hits on platelets. What is the parent cell of a platelet called? Megakaryocyte, right? Okay, there is a hormone, all right, that will stimulate megakaryocytes to produce platelets. Does anybody remember what it's called? What is that? Thrombopoietin. Okay, and somebody else said that too. Thrombopoietin. I'm probably pronouncing it wrong, but I pronounce things right and spell them. Thrombopoietin, right? That's the hormone that stimulates platelet production. All right, since we're still on platelets, let's talk about how long do platelets live for. Again, if you don't know these answers.
7 to 10 days, yeah.
6 to 10? Okay,
7 to
you probably
10.
get that right if it's in a multiple choice format, but I think the perfect answer is 7 to 10 days, right? So they don't live for a long time, right? Platelets, 7 to 10 days. So since we're still talking about platelets, what is one of the drugs we talked about today that will interfere with platelets? That will cause, it's kind of like a prophylactic thing to take.
Aspirin.
Aspirin, right? Okay. Does aspirin affect this immediately, or does it take a long time? It's about an hour, okay? I don't know what your book says. It's gonna be like 45 minutes to an hour or something like that. And I don't think I told you today, and this may not be on your test, but just so you understand this, once aspirin takes effect in platelets, it affects that platelet for the lifespan of the platelet. So when you take one aspirin, that should affect the platelets that are in your body right then for 7 to 10 days. Although a lot of doctors will tell you to take the baby aspirin every day. All right? Now, see, we just covered a lot of stuff about platelets, all right? That's a lot of good information. All right, so moving on, now you're gonna just have to know, for example, what's involved in a primary clot versus a secondary clot, right? Like vessels, vasoconstriction and platelets, that's primary. Secondary involves the coagulation proteins, and I think the book is gonna say enzymatic reactions, okay? All right, so the coagulation cascade. Remember I told you, hint, the field goal post that I drew on the board or the field goal post that's in your book, it's a good idea to draw that out, all right? You guys want me to draw it out again so we can talk about it? Or okay? All right, so if I was taking that test, I would draw this right here. I hope I remember all this stuff. Y'all may have to help me a little bit. First of all, tell me what pathway this is. Intrinsic, right? Remember, it's as you're looking at it.
Intrinsic. The other one's extrinsic. That one's PT.
Intrinsic pathway. You guys would be welcome to take a picture of this if you want after the row. What pathway is this?
Extrinsic.
Extrinsic pathway. Okay, tell me a test that monitors this pathway.
PT.
PTT. I just want you guys to realize why I'm writing all this stuff. What's a test that monitors this pathway? Proton, right? All right. What is a drug or an anticoagulant that affects this?
Heparin.
Heparin, right? What is an anticoagulant that affects this pathway? Coumadin/warfarin. Good. All right, so intrinsic, extrinsic, what's that pathway?
Common.
Common.
Common. I'll try to. All right. All right, so we've already got quite a bit of information up there. Do you agree?
Yes.
All right, what factor starts this off?
12.
12. The test will have Roman numerals.
Okay.
So I'm just letting you know, if you don't know Roman numerals, you need to study them this week. Okay. What does 12 link up to?
11.
11.
8.
What comes next?
9.
9. And then what comes
8.
next? 8. All right, so those factors make up the intrinsic pathway, the extrinsic.
3 and 7.
3 and 7. Now, I'm not sure if in your book, but I'm not even gonna write 3, I'm gonna write tissue factor up here, tissue factor, and then I'll put a 3 up at the top. But this is one, Darren and I were talking about this yesterday, this one doesn't get a lot of credit, okay? For whatever reason, they don't like to talk about it, but tissue factor is involved in the extrinsic pathway, but the main factor that you need to know about the extrinsic pathway is what number?
7.
7. So, you got factors here, you got factors here. Now we need to start talking about the common pathway, all right? So I don't care what order, tell me what I need to draw here.
10, 5, 2, 1 to
10,
13.
5, 2, 1?
Yes.
Okay. 10, 5,
2,
and
1. And then it had dash and then 13.
We're gonna have
2, 13.
13.
Remember all that crap.
Okay, all right. Common pathway, 1, 2, 5, 10. So if you will draw this on your exam before you start, I mean, if you want to do it in your head, you can, but this is a surefire way just to be able to refer it. Because there's going to be all kinds of questions on the test that says, you have a factor 9 deficiency, which test will be elevated.
Do you know that calcium is on the table?
Yeah.
That's 4.
We got calcium and platelet factor are, what else have we got there? Calcium, what else does it say in your book? Anybody have to fill the post? Probably about
I don't know.
Okay, calcium. Calcium, gotta have calcium, all right? This is a typical question that will be on your test, all right? You have an elevated PTT, a normal pro time, and a normal bleeding time. Which factor deficiency would it be? You'll have multiple choice. Hear me out a second. You'll have multiple choice. You have to pick out the only answer that can be correct. In other words, I'm gonna have one of these factors there, okay? But I'm banking that you go, okay, the PTG is abnormal, the pro time's normal, so it's not over there, okay? And if the pro time's normal, it's not in the common pathway, right? So you'll have to look on your multiple choice and pick out which one's over here. Again, draw this field goal post so you can refer to it, yeah.
I know Catherine asked us the other day, where's factor 4? Oh, it's on the.
Factor 4 is ionized calcium, so
Is
that's,
that why you just wrote calcium?
Yes.
Yeah, okay.
Yeah.
Yeah, it's between 5 and 2. Thank you.
and before I forget, there's one question on the test where I put a Roman numeral and I say, what's the name of this factor? I'm not telling you which one, 13 factors, you gotta learn 13 names, okay? Actually, you don't have to learn 13 names, factor 6 is non-existent, right?
Right.
So you won't study that in vain.
Do we have to know the high molecular weights and?
No. High molecular weight kininogen? No, don't have to know about it. Or precalculating. This is what I want you to know. You should be able to answer a lot of questions about this right here. And you are gonna have to know the basic functions of them, but you should know which one I'm gonna ask you, because I've talked about it, like, I mean, how many times have I said so far that thrombin's primary role, or what everybody talks about in the books, is it converts fibrinogen to fibrin, right? So again, you definitely need to know, this is fibrinogen, this is prothrombin. Prothrombin is the inactive form, but if it's acted upon, prothrombin is converted to thrombin, and then thrombin is what converts fibrinogen to fibrin. Now, thrombin's got a lot of other roles besides just that, but you're gonna need to know that, okay? Thrombin is what converts fibrinogen to fibrin. Fibrinogen is the major substrate of the coagulation system. This is in vitro. This is what you've been doing in there, okay? This is what you can calculate out by doing a proton and a PTT. Okay, so let me give you another scenario. We do a proton on a patient and it's totally normal. Okay, I'm guaranteeing you this patient has a factor deficiency. The proton is normal and the PTT is normal. What is the only factor it can be?
Factor 13,
Good. Why would it be factor 13?
because it's not a.
True factor?
It's the only factor, okay, that a proton or a PTT will not be elevated. There's a certain test we do for factor 13. Does anybody remember it?
No.
It's called a 5-mole urea test.
Oh.
Remember, it's where you actually basically you make a clot form and then you go and check that clot after so long and the clot loses its stability. Think about it, fibrin stabilizing factor, right? If you don't have it, the clot will form, but it will easily break apart. It's not a good clot. It's not an irreversible clot. In other words, because factor 13 didn't swoop in, and I think I told you it weaves it like with thread and makes it where it's a real compact, irreversible clot. If you're deficient in factor 13, remember I was telling you guys about the keloid? I got a keloid because factor 13, maybe I'm factor 13 deficient, right? That's one of the side effects of that. Okay, so remember these are the contact activation factors, right? So now that we're talking about this, I said this once today, but I'm gonna say it again. If a patient has an elevated PTT, all right, there's only 3 things that can be wrong with that patient. So name one, two. Tell me 3 things that can cause a patient to have an elevated PTT. That's one. They're taking heparin.
Circulating.
Lupus.
Boom, good. A lupus anticoagulant. If you write lupus anticoagulant, circulating anticoagulant, you'll get credit, all right? But that's the 3 things that will cause a PTT to be elevated. What is the most common thing to cause a PTT to be elevated?
Heparin.
Right. Now, this is not on the test, but I want you guys to leave here after you take this course knowing this. If you think about it, if you're working in the Coag department and you're doing PTs every day, would you agree that the majority of all PTs are going to be normal or going to be abnormal?
Yeah.
Why would the majority of them be abnormal?
They have to have a reason to order.
Boom, perfect. Think about it. Doctors order protons because their patients are taking Coumadin. Why else would they order it? I mean, unless they come in and they're symptomatic and they're thinking, oh, you may be one of the rare people in the state of Arkansas that has a coag deficiency, right? The majority of all protons that you run when you guys go to work, they're going to be elevated because the doctors want them to be elevated, right? Because they're in danger of, they've had procedures done or they're in danger of forming a clot. So it's totally normal to run 20 protons and 18 of them be abnormally high, right? Same goes with PTTs. If you run a PTT that's 30, that's dead normal. I mean, if the doctor knew that before he ordered it or she ordered it, they probably wouldn't have ordered it, right? Because they just ordered a test that's perfectly normal. Because doctors are supposed to have reasons to order tests. In other words, you're not just supposed to, every patient you see, like, you know what, I'm gonna run a proton on you, you may have a factor 7 deficiency.
Yeah, just because.
You know what I mean? They're not supposed to do that.
Well, that makes sense, cause some doctors just order the same thing on everybody every time, so you call that specific doctor special, because they don't wanna know what's going on, or just it doesn't lab.
Right.
Just wanna order all CRPs with this one, I'll order all Ceterates and then AR, and Ceterates take an hour, so half the time, that's wrong.
Right.
So if I say which of the following factors are involved in the common pathway, all right, and you're looking at a multiple choice question, you have to pick out the one that's one of these, right? That's some of these questions, how they'll be designed, right?
Or you could say which one of the following are not involved in the compound, and then you have three of them that are, you think are the.
So a patient is on heparin therapy. You guys tell me, a patient is on heparin therapy, the doctor orders a ProTime and a PTT. How will those results look?
PTT will be elevated.
What about the ProTime?
Normal.
Good, so can you recognize that? If I got
Right.
those, but I'm gonna have them where they all look alike. ProTime normal, PTT elevated, ProTime elevated, see what I'm saying? So you gotta pick out the right one.
So you wanna use your question on the test and say, a factor 2 deficiency is the case with this patient, what tests will be elevated? And that the correct answer for that would be both the PTT and the proton.
Exactly.
And the reason why is because 2 is in the common pathway.
What if I throw a bleeding time in there just to confuse you guys? What should the if you have a factor deficiency, how should that affect your bleeding time?
Make it longer.
For the most part, your bleeding time will be normal. Think about it, factor deficiencies, they really don't have to do with, remember, a bleeding time is like you initially cut yourself. What did I tell you has to be involved for your bleeding time to be good? Platelets. Bleeding times now, there is one of the factors that your bleeding time will be abnormal, okay? And that would be, if I was to throw in and say factor 1. Because remember how important fibrinogen is in platelet aggregation? Remember that big platelet on that page that's coming in to link up with another platelet? You gotta have fibrinogen as a mediator right there. So now your bleeding time would be abnormal with a fibrinogen deficiency, but for the most part, bleeding times are not necessarily always gonna be abnormal if you're missing a factor, okay? Remember, factor deficiencies doesn't necessarily mean that you're going to bleed longer from an open cut. It means like internally, it's like you develop a bruise, it's like a ooze, okay? But when you're talking about cutting your skin, now the major things to heal that section is gonna be exposed collagen, von Willebrand factor, okay, and platelets. That's the things that will form that initial plug. But if you don't have the coagulation factors, that's where you can't get that irreversible clot to form. Does that make sense?
Mhm.
Remember, you've got a primary clot, which is the platelet plug, all right? But secondary coagulation is when the coagulation factors swoop in. Tell me a difference, I don't know if you guys have been studying, tell me a difference between acute ITP and chronic ITP.
Oh, the
Idiopathic
age,
thrombocytopenic purpura, remember those?
the length of time is different, and chronic, it lasts months to years, and acute, it can last 2 to 6 weeks. And it usually affects kids.
Bingo, kids. Acute ITP usually follows a viral illness that a child has had. Chronic ITP is usually from an autoantibody that occurs, an antibody to platelets, right? Make sure that you look at those two conditions, acute and chronic ITP, right? There were lots of other conditions too. I wouldn't spend forever studying those conditions. Learn the basic things that make them different from the other conditions. Like we talked about hemolytic uremic syndrome, we talked about Glanzmann's thrombocythemia, we talked about ITP, all right? We talked about DIC. So don't forget those disease states, all right? Especially in chapter, I think it was chapter 16. That has all those different disease
Yes.
states. Blue top 2, what's the name of the anticoagulant?
Sodium citrate.
How does it work?
Calcium.
Calcium.
It
Binds
binds.
calcium. Does everybody know that? Sodium citrate, okay, blue top 2 prevents the blood from clotting because it binds calcium. instead of going over those problems, you wanted to go over on that worksheet where I write the formula and you have to adjust the sodium citrate. I wanna do something different in the review for it. I'm not gonna go over that calculation with you, okay? There's a reason for that. You guys should be able to read my mind on that, but I do wanna go over this, cause this involves a direct question on the test. All right, if I have a patient, if I grab that one more time. All right, if I have a patient.
Throw it away.
That's a good idea.
Yeah,
Throwing it away.
it's over there at the back of the.
All the way to the back.
That's fine.
Yeah.
I have everyone in the room for it.
All right. Okay, instead of doing those formulas for questions 1 through 4 on your worksheet, I think you should study this. This is a patient with a real high hematocrit. Do you agree? See all those red cells?
That's the plasma.
This right there, that's the plasma in this tube. And this is abnormal, guys, right? Okay, I mean, normally your red cells should take up about half of the volume. This is a person with a real low hematocrit, and this is the stuff that we test right here, okay? Again, this is plasma, this is plasma. Now remember, there's an anticoagulant that's in this tube that makes up a perfect 1-to-9 ratio of anticoagulant to blood. You might want to remember that too, 1-to-9 ratio. Because we have so little plasma in this tube right here, you gotta kind of think it through. Like if I saw this question on the test, I would draw this exactly the way I'm drawing it so you can think it out. Okay, the patient has a real high hematocrit, all right? That means there's very little plasma, okay? So that means there's probably too much anticoagulant in that tube for the small amount of plasma that we have. That makes sense when you think through it? I mean, I have to think through this to teach it because it's hard for me just to tell you that, but if I draw it on the board, it makes sense to me. Now we have a tube that has this much plasma, okay? So what would we do to that tube? Would we want to take away anticoagulant or actually add more anticoagulant?
More on that.
We want to add more, right? Because we've got all of this plasma, it's abnormal to have that much. So we truly have too little anticoagulant in the tube for all of that plasma because this patient's hematocrit is so low, right? You'll do better to know that for the test than you will to be able to do that formula in that math problem, okay? Because that way you're understanding why you're having to do that correction to begin with. If a patient has leukemia and blasts are starting to form everywhere in the bone marrow, would that cause the platelet count to be low, normal, or high?
Low.
Why would it cause it to be low?
The blast
Pushing out.
routed out.
Good, good. There's a myeloproliferative disorder called essential thrombocythemia. I'm thinking that this maybe was in chapter 12 of your book that talked about this disorder, okay? What effect will that have on platelets?
Leukemia,
Decrease?
Essential thrombocythemia causes platelet counts to skyrocket, okay? So you're gonna have thrombocytosis in that condition. You might wanna go back and review that condition, just read that very thing right there, okay? Essential thrombocythemia will cause you to have a real high platelet count. That's a myeloproliferative disorder. There's a couple of conditions that you will see schistocytes on a peripheral smear. Somebody tell me one of them. DIC, okay? If DIC is not one of your multiple choice answers, there's another condition that you might want to go back and review called TTP. All right, that's one of those disease states, TTP. How long do we have to test a PTT once the blood's drawn?
4 hours.
4 hours?
4 hours. I think we talked about this, and we were wrong on it. We said probably it's not, it's the PTT. The PTT, you have 4 hours to do the test on it.
Cause the other one's longer,
What about the pro time?
24.
24 hours. One of those is on the test, but you're gonna have to learn both of them, okay? A PTT, you have to do that test within 4 hours, all right? A PT, you got up to 24 hours to run the test. Okay, let's talk about one more thing with the blue top tube called platelet satellitism. You guys remember us talking about that? If you actually are looking at a smear and the blood's not clotted, but when you're looking at that diff or you're doing a scan, you notice that the platelets seem to be forming little rosettes or little platelet clumps. Your book tells you around a lot of the neutrophils. Actually, it's also eos and basos, but around the polymorphonuclear cells. What do you do if that happens? A blue top, and there's a point in your book that talks about that, okay? Under the sample conditions, it says that you're supposed to draw a blue top tube, you run the platelet count, and then there is a number you need to multiply for due to the dilutional effect.
1 to 1.
1.1, okay? That's what you do whenever you have what's called platelet clumping, or, I hate to say it because text don't call it that, the book calls it platelet satellitism. If a patient is vitamin K depleted, what will their pro time and their PTT look like?
Both be elevated,
Both be elevated? Why would they both be elevated?
because it's in a common pathway.
Which one's in the common pathway that's affected by vitamin K?
Can it be all of them?
Right, you're right. You're right. The answer's right, okay? If you'll remember that vitamin K has an effect on factors 2, 7, 9, and 10, all right? So look, right here it tells you your pro time and PTT are both gonna be elevated. Do you agree? Because it's in the common pathway. But even if you don't go there, okay? If you go here, 2, 7, 9,
And 10.
and 10, I mean, it hits a double whammy on the common pathway, right? So if I tell you a patient is vitamin K depleted, what will the test look like? You need to recognize, okay, the pro time's elevated and the PTT is elevated. The lecture today, we talked about arterial thrombosis and venous thrombosis. One of the big things that I said twice is that arterial thrombosis is generally made up of platelets. Okay? That's all right. Mine went off the other day. This is all of them going on. Okay, let's talk about hemophilia A and hemophilia B. This is real easy study material. Factor VIII, which one is it, Ann? Is it hemophilia A? Okay, what about hemophilia B? Factor IX, correct? Okay, so if a patient has hemophilia A, which test is gonna be abnormal? PTT, right? Pro time should be okay, all right, but the PTT should be elevated, right? Everybody with me on that? What about hemophilia B? Which results should be elevated? The same.
Yeah.
What's the number one reason people die from hemophilia A?
Intracranial bleeding.
Intracranial bleeding. Said that about 3 times and it's on a review question. No one had better miss that question, okay? Make sure you study protein C resistance. I talked about that a lot too. Activated protein C, okay? It affects factors 5 and 8. The only way it doesn't work is if you have a mutated factor 5. Remember I told you about 2 factors that can mutate, factor 2 and factors 5, right? A mutated factor 5 will not allow protein C to deactivate factor 5. Because of that, you'll tend to clot. We covered that a lot today. What kind of treatment do you give to hemophilia A patients? Okay.
Well, FF.
Yeah, you could give that, but we talked about what is the most purest, what are your review questions talking about?
Pyroprecipitate.
Recombinant products. Okay, you guys are right about FFP, but remember what we talked about dangers of that, okay? Now, granted, most people now are all tested for HIV and hepatitis and all those horrible things that happened to hemophiliacs a long time ago, but you've got a review question that talks about recombinant products, okay? Remember we talked about gene therapy and all of that type of stuff, okay? So make sure that you go back and review over that. Make sure that you understand those disease disorders that we talked about, the fibrinogen. Remember, we went over it today. You can have afibrinogenemia, okay, dysfibrinogenemia, and hypofibrinogenemia, right? One of them is a qualitative disorder that basically you have the fibrinogen, it just doesn't work. Which one is it? Dys. Which one is the worst one? A, right? Because you can't even hardly detect the amount of fibrinogen. This disease is usually triggered by an underlying pathological circumstance occurring in the body. As a result, the hemostatic system becomes unbalanced, causing hyperactivation of all the coagulation factors and the fibrinolytic system at the same time. DIC, okay, so tell me some things that might trigger a DIC event.
Snake bite.
Snake bite? Okay, now I know that I really hit that snake bite thing, but that's really not, I use that because that's a real good example of something that can trigger it, but now remember, that's probably not the most common thing. We're going into labor and delivery, that can trigger it. Massive trauma, it talks about severe infections and things like that. But yes, there is a case study in your book that involves a snake bite. You definitely might want to look at it. Okay. How does Coumadin work? What makes Coumadin an anticoagulant? What does it do? What does it have an effect on? Remember I told you guys a story, my mother has to take Coumadin or warfarin, and she has to eat a certain diet because, right, because how Coumadin and heparin, or how Coumadin and warfarin works is it inhibits the vitamin K dependent factors, okay? Which one of those majorly is factor 7, okay? Right? So that's how Coumadin works. Coumadin inhibits the vitamin K dependent factors. How does heparin work? We talked about this today.
As an antithrombin.
As an antithrombin. Up till now, we talked about purple tops, right? They work, they bind calcium. Blue tops, they bind calcium, right? Green tops have heparin in them. Heparin causes the blood not to coagulate because it is an antagonist to thrombin. It is an antithrombin, all right? So that should help you answer a question there. What is that disease state we talked about today to where they take a baseline platelet count before they give somebody heparin? And then once they start giving them heparin, about 5 days into it, the platelet count drops dramatically.
Oh, it's at the very end.
HIT?
Good. HIT. And figure out which word goes with it. Heparin-induced thrombocytopenia. Okay, HIT. The book talks a lot about that. Okay, a patient is not on any type of anticoagulant therapy, but they have a prolonged ProTime and a prolonged PTT. What would this indicate? Which coagulation deficiency?
That's gonna be common pathway, right?
Right. Does everybody agree with that? Everybody understand what Wendy just said there?
Yeah.
What was the deficiency?
It would be in the common pathway, both of them are elevated.
Oh, so just what pathway?
Yeah, it would be a pathway, it'd be one of those on the, or say common pathway, it's the case there.
If a person has splenomegaly, what effect will that have on the platelet count?
Lower.
Yeah,
Why?
because they're all collecting.
In the spleen.
Yeah.
The spleen gets bigger, right? And so the platelets, that's really, it's not a place where platelets are reserved, but your spleen usually contains, I think I told you guys, 20 to 30% of your circulating platelets are in your spleen. So if your spleen gets bigger, they say that your platelets tend to pool up in that large spleen, all right? So now you got splenomegaly, all right? So splenomegaly can cause a decreased platelet count due to an altered distribution of platelets. You guys remember us talking about that? Okay, so I'm Dr. Turner, and I come in, and Kennedy's got a large spleen, so I take it out. I'm like, we're gonna take your spleen out, all right? We're gonna do a splenectomy. Now what do we have to worry about in Kennedy?
A high, it
We gotta
increase.
worry about thrombocytosis, right? Because all those platelets that were in Kennedy's large spleen, right, are gonna spill over into the blood, and then we're gonna have a transient thrombocytosis. It's not that she truly had thrombocytosis, but because we took her spleen out, and that's kind of a bloody surgery, we pulled a lot of those platelets into the bloodstream. One thing that I want you to take also from this class is that don't make people sicker than they already are. We talked about that when I told you about doing dips, okay? So if a physician is making rounds on a floor, they come across a patient that they're supposed to look in on, and they see that that patient had coags drawn this morning, and this physician she knows that a normal PTT is 30, okay? And she looks on the door and she says, okay, they ran coags this morning and they got a pro time of 12 and they got a PTT of 65. And then she's looking at that chart and she notices that they're taking so many whatever units of heparin every 4 hours. What do you think she walks away from that room thinking?
Is the heparin therapy making the PTT higher? But does she wanna redraw maybe later too, to just monitor out some?
Well, they do draw, patients that are taking heparin are supposed to have their PTT ever so often. It has to be drawn. It's not just a one-time thing, because when they give heparin, they usually, when they first give it, they give it in a bolus, a big, huge amount, but then they taper it back, okay? But what does she walk away from that room thinking? Is she gonna call their surgeon? I mean, what's the deal? Her PTT is 60. That's what I want you to know, okay? I will try to trick you on tests, because I want you to recognize things that are absolutely normal. You gotta be able to do that. You can't go into this field thinking, oh my gosh, this person's sick, I gotta call. You know what I mean? Because it's like, just remember, patients have symptoms. That's why doctors order tests. A lot of times doctors order these tests, they know the proton's gonna be high, right? Because they've had this person on Coumadin for 3 years, but they still have to run it ever so often to make sure that they don't need to adjust the medication. So recognize things that's normal. Just because they have a high PTT, it does not mean, okay, they got factor deficiency or they got a circulating anticoagulant. Okay, you need to remember, okay, Britt told us that, 9 times out of 10, if they've got a high PTT, it's because they're on heparin. Okay, it's totally normal. Yeah.
Question, you said whenever they draw these patients that are on heparin, that they'll let you know they're on heparin before you run the test usually on the paper, like check if they're on heparin therapy? Because if you get a high reading, you still have to call the critical, but put in your comments that the patient's on heparin therapy?
No, actually, unless it is really high, you don't have to call it. If the patient's taking heparin and they put they're on heparin and you get a result on the analyzer that the PTT was 60, you don't have to call that result because that's totally normal, or 65 even. I think that our cutoff level, when I worked for a PTT, I believe it was any PTT that was greater than like 92 if the patient was taking heparin. But if it clearly says the patient is not taking any anticoagulants, then we had a cutoff value of like 40. See what I'm saying? So you gotta pay attention to stuff like that. And you gotta hope that the nurses take the time to tell you that. Because guess what? If they don't put anything, guess what you gotta do? You gotta take for granted that they're not taking anything and you're ending up calling results. And trust me, there's nothing that'll make you more furious if you're real busy in the morning and you call up to document and say, I need to talk to the nurse at Britt Turner, and then they come and they go, oh, well, yeah, they're taking heparin, that's, and you're just like, you gotta put that down, because I wouldn't have had to call you and stay on hold for 10 minutes, you see what I mean? Trying to call that result. Off of your worksheet, the calculations for INRs, you need to be able to do that, okay? You want me to do one on the board real quick, or kind of go over it just for a second? An INR calculation, take the value that you got for the pro time, let's just say I'm doing somebody that's dead normal. I get a PT result of 12 seconds, 12.0 seconds. I divide that by whatever pro time that the lab has established is a dead normal pro time for them. Okay.
You'll be giving us that, right? The
I'll
lab
give-
normal.
Yep, I'll give it all to you. I'll tell you all the results and tell you to calculate the INR.
Okay.
Okay, so I would take, this is my patient's value. This is my PT normal,
Range.
which would be 12.0, all right? So all you do, take those two numbers, and then we will give you, or you will look at the package insert, and there will be an ISI assigned to the lot of innovant or thromboplastin C. I would make it easy, I'm not gonna put decimals and all of that, but whether I go 1, what would my INR be then? 1, right, which is, that's one thing techs always look for, INR of 1 means completely normal, okay? But, now, any power I put on this, the answer is gonna be 1, okay? But if I had, for example, if the pro time was 36, which this would be about what a patient taking Coumadin would be 36, okay? And then we had a 1, what's the INR? 3, right? INR 3. And as we talked about in today's lecture, physicians know what the INR needs to be if they have a patient taking Coumadin, depending upon what their disease state is. If they had a heart valve replacement or something like that, they have a range that they keep. Like a doctor might say, okay, I need that patient's INR to be between 2.5 and 3, okay? If that INR gets below that, they're probably gonna give them more Coumadin. If it's way above that, then they're gonna knock off the Coumadin for a little while, or at least decrease the dosage. And all you guys do that.
Yes, sir.
You're also gonna need to know how to do serial dilutions. This is what we talked about, serial dilutions. Why do you work a lot of points? Twofold, I would, start off running twofolds. If it's on the test, it'll probably be in a twofold serial dilution format. I will tell you one thing, I am just to try to make it as lifelike as possible. Usually if I ask that question, I'm going to tell you which pipettes you have available to work with. Like, you're not gonna be able to do that in your own, like I'll say, you have a 1 mil pipette and a 200 microliter pipette. Tell me how to do a twofold serial dilution using 100 microliters of patient sample. You have to understand it. You can't just memorize away and always go with it. I'm going to throw things in there to where you can apply it. So in other words, one of those pipettes you don't even need to use. Because if you do a twofold serial dilution, generally, that only really requires, most of the time, 1 pipette. Because you're adding 1 part to 1 part, right? I mean, it might require you to put a little more in the first 2, but other than that, you should, it's kind of like, I'm trying to make you decipher how you do that. What you're gonna do a fibrinogen titer today, after we get finished with this, and so you are gonna have to do a twofold serial dilution, but your lab manual is gonna give you perfect actually, I'm gonna modify the directions a little bit where it's exactly the way we went over in class. Okay, so platelet drugs, aspirin, anticoagulants, heparin and Coumadin, fibrinolytic drugs, tissue plasminogen activator, streptokinase, urokinase, right? I just covered all 3 things about coagulation pretty much, right, as far as the drugs that affect it. So make sure you learn that. I have not went over the entire test with you, okay? I went over enough things though that you should pass the test off of listening to this review and looking up what we did. I did not go over enough information that you'll make a 99 on the test. Only way you're gonna make a 99 on the test is you're gonna have to know this stuff, okay? I went over enough that you should make a high C, okay? That's if you just don't do anything but go home and basically look up what we just reviewed, right? I went over enough stuff that you should be able to answer every case study based on the review that I just gave you. okay? And I'll prove it. If you disagree after you take the test, somebody play the recording back, alright? I don't normally do this. This is Jason in my first year. I know what your grades are. I'm not trying to give away a grade. But I know a lot of you need to do good on this exam, so I whittled down a lot of information for you. But to make an A on this test, you are gonna have to go back and you're gonna have to look at definitely ITP, chronic and acute, okay? Hemolytic uremic syndrome, TTP, all those disease states that we talked about. What causes platelet counts to be increased? What causes them to be decreased? Go over the review questions, okay? Because there's certain review questions that are on this test that I didn't go over, but if you do the review questions, you'll probably go, oh my gosh, that's word for word, okay? So study, you gotta study this stuff. If you don't study and you don't put forth, I'm not trying to lecture you guys are adults, but most people can't just read over this stuff one time and have it, you know?
Yep.
So if you're having to study a lot, you're normal. Any questions? Okay, I know we went for a long time. Let's take about 20 minutes. It's up to you, whatever you guys